Okay, so thank you very much for the invitation. Much appreciated. So what I will, so as Dr. Jude mentioned, you guys, maybe a lot of you know me, and the people who don't. My name is Ahmad Alkhamis. I work in Kuwait University. I'm a general and colorectal surgeon. And today we're going to discuss the common conditions that I've been faced with, and I think you will be faced with as general surgeons. I mean, this lecture, as I mentioned before, it's mainly geared toward the R4 and R5, but I think everybody can get something out of it. I made it very simple. It's into the, I'm going into specific points, not a lot of philosophical talk, more about practical and what you will see in real life, and I think what you need to understand with some physiology just to make it a little bit scientific, okay? So let's do this, okay. So the objectives is really, it's really simple. We're gonna go through the most common causes of large bowel obstruction, and I will give you some of my tricks and tips of how I do think and how I manage, and how when you see these type of patients, how do you present them to your senior or your consultants, and what's the best way to manage them and things like this. Of course, there are we have five MCQ questions. So we'll show you these questions, and then you guys, I think the system here is that you answer them, then I'll go through the lecture, and hopefully by processing the data that I will present in my lecture, we're gonna put these questions again, and then you're gonna guys hopefully get better percentage of successful answers. And at the end, we will have 3 case scenarios. Now, these 3 case scenarios might be related to the lecture, might not be, because the idea is to stimulate the R5s so they're ready to do their oral exams when the time comes. These are real questions that have, we've seen in real life and we've seen in real exams in the past. So 3 nice questions you can entertain yourself with at the end, okay? So now I think they're gonna put these questions for you guys to, where is the, Dr. Jude, there's something that's gonna show up now, yeah?
Yes, the question is up now.
Yeah.
Actually, the question was up in the beginning, so we'll move
Here,
on to the
question 1. Everyone
because I
can
don't
see
see
it,
the question. Do you guys see it?
Yes.
Okay, I don't see it, so I will, sorry guys, do I read the question, or do I read the question to them, or do they just have to answer, or what do I do?
Read the question. Read the question,
okay.
Yeah.
Okay, I'll read the questions. Okay, so basically, this is a 48 years old male patient come to the emergency department with an obstructing sigmoid mass. You do a staging CT of the chest, abdomen, and pelvis, and you see a sigmoid mass causing dilatation of the colon up to the cecum, but there's no dilatation of the small bowel. You notice also, unfortunately, the patient he's young, but he has lung and liver metastasis. So what is the best management option here? Do you go with NPO, IV fluid, nasogastric tube decompression, and rectal decompression with serial abdominal exam, and they make a decision later? Do you go with NPO, IV fluid, and refer for urgent palliative care since he has metastasis? Do you do a colectomy and end colostomy? Do you call your gastroenterology colleague and then put a colonic stent? Or do you refer to me? Obviously, I'm happy to take any case as long as the patient's stable. So I will always give you this option. And I don't think it's the wrong answer, just to give you a little bit of a heads up in terms of answering the wrong and right, with choosing the right or the wrong answer, okay? So that's question 1. Do I go to question 2 now? So a 48 years old female patient present to the emergency department with obstructing rectosigmoid mass. Again, the same thing. CT this time showed a rectosigmoid mass causing dilatation of the colon up to the cecum with mild to moderate free fluid. You go to the OR, you make a decision already, you go to the OR, and you notice that there is a rectosigmoid mass with colonic dilatation and there is a tear in the cecum. This is 2 case, huh? And also you identify some liver mets. What's the best management option? Do you go with a subtotal colectomy with endoleostomy? Do you go with subtotal colectomy with ileorectal anastomosis? Do you do a colectomy with colostomy? Do you do a resection with ileocolic resection with primary anastomosis and anterior resection? So RS is wrong. So what I mean is, do you do rectosigmoid resection and ileocolic resection, and you anastomose, and then you do a diverting stoma? or you refer to me again. You just call me, say, Ahmed, can you come? And I'll come overnight. All right? So that's question number 2. Okay, so now, do I go to the next question? Guys?
Yes, we can
Hello?
see it. We can see it, yes.
Can we go to the question 3? Because I see now question 2 in my, or do I switch?
Switch from your side.
Okay, so question 3.
They can follow it even on the PowerPoint. Yeah.
So question 3 is a 55-year-old female patient present to the emergency department with the sigmoid volvulus. She is hemodynamically stable. What is the best management option? Do you go MPO, IV fluid, NGT, rectal tube, and serial abdominal exam? Do you do colonic endoscopic decompression and then discharge and operate later when she's stable in the outpatient to arrange another date? Do you do colonic endoscopic decompression and then you do sigmoid resection in the same admission? Or do you do colonic endoscopic decompression and you detours the sigmoid and you pexy it at a later date at a later date in the same admission? Or do you call me and refer to me? Okay, so this is good. So we'll go to the next question. Question number 4. So you have a 55-year-old female patient with who present to the emergency department last time with a sigmoid, now with a cecal volvulus. Okay, she is hemodynamically stable, the same. What is the best management option? Again, MPO, IV fluid, nasogastric tube, rectal tube, and serial abdominal exam. Do you do colonic decompression by endoscopy and discharge her and then operate later when she is stable? Or do you do colonic decompression and cecal resection at the same admission but in a later date? Or do you do colonic decompression and detortion and then you do a pexy at a later date in the same admission? Or do you just go for ileocecal resection from the beginning? Or do you call me again and refer to me?
So we can give them 1 minute to think about it. Too many options, yeah.
Option F is always the best. See, you're always safe to pick option F, in my opinion. I'm biased, maybe. It's almost never wrong. It just cannot be wrong. So F is always a good answer if you don't know which answer to pick.
And we'll go over this question later at the end for anyone who were not able to follow the question with us.
Okay, we're going now to the last question, 5. Okay, so it's a 65-year-old female patient. You are seeing as typical story in the orthopedics floor for the management of what seems like somebody already gave you the diagnosis. It's Ogilvie syndrome, pseudo-obstruction. And she's hemodynamically stable. They've already tried to correct the electrolytes and they failed to resolve the large bowel obstruction from the Ogilvie. What is the best management option? Do you continue the same IV fluid, MPO, NGT, rectal tube, and serial abdominal exam, and give her extra days? Do you do colonic decompression and discharge when stable? Do you give neostigmine IV? And if they open up, you give PEG to clean the bowel and then discharge when stable? Do you do colonic decompression with an endoscopy and then you do a laparotomy to resect a specific segment? Or again, do you call me and ask for help?
So for everyone, don't worry. Later we'll go over the questions with the correct answers.
Okay. I keep saying F is the last option is always a good option. Okay? So now we're going to go into the lecture. So you're going to notice every now and then I'll be repetitive. The reason I'm repetitive because I think it's important. So just, you understand why I'm repetitive, okay? So we'll start with basics and then we'll go up, okay? So large bowel obstruction, obviously the definition is any obstruction distal to the ileocecal valve. The reason we're discussing it today, and I like to give this lecture, I even give this lecture in a simpler term for the medical students, because I think this is one of the major diseases that the management most of the time is actually a surgical, general, it's some sort of a surgical intervention. Unfortunately, because the type of population we are faced with these patients, at least in the past, maybe that's changing now, is the older patients. So the mortality and morbidity is relatively high, 46% morbidity and 18% mortality. I think the way you're always going to have to look at it is the large. I think this is very important and really critical when you collect the data from the patient. Is this obstruction a partial bowel obstruction, large bowel obstruction, or is it complete? And I think it's really simple by asking the patient, did you pass any gas or did you pass any stool? And you don't need an X-ray, I think, to make a determination about the degree of obstruction and how urgent it is. So, I mean, I think this is one of the ways. I mean, for me, it's becoming more natural to think about it, but I think if it's not very natural for you to form a differential diagnosis when you see a patient, it's always nice to divide the etiology of the potential differential diagnosis. So large bowel obstruction, you can look at it, is it an intrinsic obstruction or is it an extrinsic obstruction? So in terms of intrinsic, I think the most common cause is colorectal cancer, followed by complication of diverticulitis and volvulus. In Eastern Europe, when you look at the data, volvulus is a little bit more common than maybe colorectal cancer. And then you can also look at it, is it a dynamic cause of large bowel obstruction, which what we just talked about is pseudo-obstruction like Ogilvie. And I think this is one nice, very nice division of the most common differential diagnosis for a large bowel obstruction. Most common is neoplasia, volvulus, inflammation. I think diverticular disease and Crohn's, you guys are going to talk about in different lectures. Fecal, impaction. The typical story: patient is constipated and then they have overflow diarrhea. This is really the typical story you get from the elderly patients. Of course, you always have to make sure it's not an inguinal or abdominal hernia or even internal hernia. If the patient had history of recent significant weight loss or bariatric surgery, you can get sometimes colonic obstruction, though it's more common to get small bowel obstruction. Intussusception. I'm not going to talk about this, but I think for any adult patient with intussusception, it's cancer until proven otherwise. So for you, you can always do some sort of oncological resection for it. Never try to reduce the intussusception. Ogilvie, we're going to talk about a little bit. Ischemic stricture, we'll talk a little bit. Foreign body, self-explanatory, and I'm not going to talk about, okay? So the pathophysiology, I think these are the two slides. I think we'll talk about pathophysiology. If you don't get this slide, the next slide is simpler. So basically what happens is that you have a moderate, you have an obstruction, which will present with proximal bowel dilatation. And then what happens is that you have this ileocecal valve, which can be, that's always this question, yeah? And I think I want to get out of the scientific part a little bit and just talk about real life. So I always say this to my colleagues and my residents. Now, if you call me at 2 a.m. and then you say, Ahmed, I have a large bowel obstruction. If you don't tell me about the ileocecal valve, you're not going to get my attention, and I'll be already getting agitated because you wake me up from sleep. But if you call me and you tell me I have a patient with large bowel obstruction and competent ileocecal valve, you're going to see me already wake up and already prepare myself to come to the OR to help you. So I think it's really extremely important for large bowel obstruction, the concept of understanding the ileocecal valve. Now, I'm going to assume most of you guys know, but I'm just going to explain it. Now, if you have a competent ileocecal valve, unfortunately, this is not good, because what's going to happen, you're going to have a flow of stuff coming from the intestine and the gastric juice and the pancreatic juice going through this valve into the cecum. And then you have this large bowel obstruction distally, let's say in the sigmoid. And this large bowel obstruction is pushing everything upstream toward the ileocecal valve. Now, if you have an incompetent valve, you're going to push everything up to the small bowel, and then you're going to vomit. And you're going to have small bowel dilatation. And this, if you put an NGT, you can decompress the patient. And I've done a lot of these cases. Actually, they can do well by resuscitating them overnight and then maybe operating later. You can do it laparoscopically. You can do it like almost semi-elective. Now, if you call me and you say, Ahmed, I have a large bowel obstruction, but unfortunately, it's a dilated cecum, dilated colon, but the small bowel is collapsed, then it's very likely a competent ileocecal valve. Now, I'm going to come and we just have to do an emergency surgery. So this is the key concept. So what's happened is you have this obstruction upstream of feces coming up. Then this is going to cause bacterial overgrowth, sepsis from bacteria translocation, gas production, more distension, more accumulation, and then perforation. And that's why with large bowel obstruction, a lot of the time, unfortunately, people forget, I ask, how's the patient? They say patient's ready for OR. I said, what are they on? They're on IV fluid. Everything is done except antibiotics because you guys forget about the bacterial translocation. So IV antibiotics is essential part of the management. This is a nice graph. I think really makes it easier to understand. You have a competent valve resulting in ileal contents pouring into the colon without a reflux. There's no reflux. You cannot, whatever goes to the colon cannot come up. And then you have increase in the intraluminal pressure, intramucosal pressure, and intramural hypotension because of this pressure, venous occlusion, followed by arterial occlusion, then thrombosis and necrosis, and then, so within 6-7 hours, the patient is dying, yeah? So that's why, or perforating. So that's why you call me 2 a.m., 3 a.m., I don't care, we're gonna go to the OR as soon as possible. And then you have this bacterial overgrowth with gas and distension and bacteremia. So this this is the real major concept that you need to understand this slide of large bowel obstruction. Now, a lot of people also ask me about, so how dilated it is. I think it's, for the cecum, my cutoff point, and a lot of the books, if you can go and review, I think they will tell you in average 12 centimeter is where you are really worried here about ischemia and perforation, and you shouldn't wait longer. If you have somebody with already 12 centimeter, then maybe you have to go to the OR. And maybe it's self-explanatory that the patient have a competent valve, because the cecum dilated enough that nothing is coming up beyond the cecum into the ileum, So this is important concept, 12 centimeter cecum. So then the patient comes to you to come to the emergency department, and they come with obstipation. So obstipation basically is no colon, no gas, and no stool. You're going to make sure that you did a digital rectal exam to make sure there's no mass that's obstructing that you can feel with no CT, and there's no inguinal hernia or abdominal hernia. Just make sure you resuscitate the patient well because they lose a lot of fluid into their bowel. And then you're going to do your tests, or you're going to do your labs, you're going to do your x-rays, you're going to do your CT. The x-rays are really important. Besides the CT scan, just remember the x-rays. We're going to talk about it when we talk about Ogilvie later. Sometimes there are conditions where you can wait a few days, and you don't need to, I don't think it's appropriate to repeat the CT scan every 3 days. By doing serial of abdominal x-rays, you can actually follow up how good is your non-surgical management of the condition. So we'll discuss this later. So x-rays, just simple abdominal x-ray is really important, okay? Endoscopy in certain circumstances, obviously. So if the patient is stable, you can do either a contrast enema or you can do a CT scan. I prefer CT because you can do a CT, look at the abdomen and give rectal contrast at the same time. Obviously you're gonna use a gastrograph in enema or gastrograph in contrast. You're going to establish the diagnosis very likely, and you're going to then know where is the obstruction so that you can make a decision of what to do next. All right? This is also like something I always mention in all my lectures. We are, unfortunately, a lot of the time obsessed about the diagnosis. And, I'm sure you guys had this incident before. So you call me, if some of my residents are listening, and then you tell me, Ahmed, I have this guy or lady, and I think maybe they have LBO. And then I ask you, okay, nice differential. What IV fluid the patient on? How much is their urine output? And there's nothing. It's just blank. Because you as a senior, you are, or R4 or whoever, are so obsessed about the diagnosis that you forget to manage the patient. So you have to remember, you don't need a differential diagnosis to manage most acute surgical emergencies. So that's why it's extremely important. I don't need to understand why the patient have that bowel obstruction. I just need to know that they have and then manage it. So how do you manage it? Almost always the same. IV fluid, electrolyte, you cannot go to the OR within 5 minutes. Yeah, you have always 2-3 hours. These are the hours where you're gonna try to resuscitate the patient. Replace the fluid, start IV antibiotics, put in NGT. So if they have an incompetent ileocecal valve, I love it. For me, it's the best the first information you can give me overnight, because then I will tell you, make sure the NGT is a large pore NGT, make sure you decompress this patient. We've done a few cases, and the patient comes with a large bowel obstruction, dilated colon, we put the NGT, we decompress, and we do the case in 1 or 2 days, and we do it laparoscopically, and they get discharged like it's an elective surgery. So remember these things. And then you're going to make a decision. When you have a large bowel obstruction, the question is always, first, am I going to do a surgical decompression, which can be either an emergency or semi-elective, or urgent? Let's call it urgent, not elective. Let's call it urgent or emergency. Or can we do an endoscopic decompression, urgent or emergently? Okay, or urgently. Sorry. So I think these are the dilemma. If you have, let's talk now. We're going to talk about a few conditions as we go through. So cancer, we're going to talk about diverticular disease. But really, majority of the time, it really doesn't matter if it's cancer or diverticular stricture or chronic or Crohn's stricture, because the surgical decision and how to manage it, it's almost always the same, except maybe, of course, with cancer, you're going to make sure when you resect, if you decide to resect, you're going to do an oncological resection versus diverticular disease or Crohn's disease. You really don't need to do that. But it's the same idea. Okay, so I have this large bowel obstruction. Let's talk about cancer today. So am I going to resect this mass in the colon? Am I going to call my gastroenterologist, decompress this mass if the patient is stable enough? Or is it too big of a mass or too low of a mass into the pelvis that maybe I just need to divert this patient and then maybe give them neoadjuvant treatment and things like this? So how to make the decision? Really, it's a lot of the time it's just common sense. If you're gonna go to the OR and resect, are you gonna anastomosis? Not, it's gonna depend on the viability of the bowel. It's gonna depend also in terms of what to decide of what to do, the location of the tumor or of the obstruction. For example, which we'll discuss soon, for stenting, if you don't want to stent a low rectal cancer, yeah, because the stent is going to cause a lot of tenesmus and a lot of irritation and agitation and a lot of slippage and a lot of problems. Anyway, I don't want to go into it now. If you give a stent for a low cancer versus if it's a sigmoid, it's perfect for stenting. So the location of the obstruction will help you make a decision. Is it a stoma? Is it a diversion? Is it a resection? Viability of the bowel, common sense, and is it resectable or not? Now, in terms of stenting, we're going to talk a little bit, I'm going to change I've added these slides lately because I think a lot of the time we don't talk about stenting because we don't see them as often and because I don't think we know how to manage them very good, at least with colon. Maybe we're much better with esophageal stents because of the sleeves and all the bariatric stuff. But colonic, we don't see them. So I'm going to go through it a little bit so that the R4 and R5s have a good understanding. And I think that's more than enough for you to know for your life as a general surgeon. So the stenting, so it can be used as a temporizing measure to allow for preoperative bowel prep or physiological correction. Because you know what, if the patient is stable enough because of the, let's say, obstructing sigmoid tumor, you can put the stent through, decompress the patients like putting the NGT, and then you can bowel prep them, prepare them for surgery, and you convert an emergency surgery, and we know that emergency surgeries the emergency surgery almost always have higher morbidity and mortality compared to elective or semi-elective. And with stenting, you can change the patient from an emergency with more likely a stoma into an elective with more likely a primary anastomosis. So I think my 2 cents are avoid stenting if you have a hemodynamically unstable patient, if you have a low rectal tumor, and if you are thinking about starting chemotherapy very soon. Because they tend to perforate with chemo, especially with immunotherapy, which we'll talk in the next slide, I think, maybe. However, use it if you think this patient can need just palliative, this is an unresectable mass, putting a stent, give them some relief, and then we know that their life expectancy are low, so it's a palliation. If the patient you think is unfit for surgery for now and you want to make them fit and bridge them for the next surgical intervention, then I think stents is good. And of course, if the patient is hemodynamically stable. So this guy, Tejero, is actually the guy who, to my knowledge, is the first guy who actually published about stenting. And because of him in 1997, colonic stenting became part of the armamentarium of general and colorectal surgeons' tools to manage large bowel obstruction. He recruited, I think the first study he did where he recruited 38 patients with colonic obstruction. He technically had 100% technical success, 92 clinical success. And then the era of chronic stenting basically was born because of this guy. And he talked a lot in his paper about patients who present with incurable disease, who have limited life expectancy, and may be able to avoid surgery and the need for a colostomy with a successful, like what we just discussed. It's just I'm repeating myself here. And so basically what he's trying to say is the stents can be used for a palliation, and also in contrast, patients with a curable disease who present with chronic obstruction, we can stent them so that we can relieve them for immediate surgery in the next day when you prep them and do bowel prep and optimize them and make sure that they have recovered physiologically from the large bowel obstruction. So in addition, patients who may have needed a large incision, and so that's already discussed. But then, of course, when you counsel the patient, you have to explain that stenting is not a guarantee to prevent the patient from having surgery even within the next few hours, because stents, unfortunately, is a procedure, so unfortunately has its own complication. So the stents, there might be a technical failure, so the stent re-obstruct or migrate, or just as you try to put the stent, you just cannot put it appropriately so that you cover because what you want ideally, which we will see very soon, you want the stent to, if that's the tumor, you want to have a little bit of the stent proximally beyond the tumor and a little bit of the stent after the tumor. So, and then you expand the tumor in the middle. So perforation is very important complication to tell the patient about. So where perforation tend to happen, they happen at the tumor site where the stent is, or proximal, not very often distal to the tumor. How do they happen? If you end up, sometimes what some people do, they dilate the stricture with a balloon for whatever reason, let's say diverticulate, and then they put the stent. If you do this, you just have to understand you can do it, but the risk of perforation is higher, so I don't advise it. How can it happen? Sometimes when you have an angulation, so the flexure, unfortunately, are more difficult. And they tend, unfortunately, to have delayed perforation because it happens not because of you pushing against the colon, it's because of erosion, so because of chronic pressure. And as I said earlier, if the patient is going to take immunotherapy, if you think they're going to take immunotherapy, just don't put the stent. It's known. It's going to perforate. So this is exactly, I don't know if you see, so this is what you want. This is a perfect placement of the stent. This is the tumor in the middle, and then you have the proximal and distal beyond the tumor. Now, so as I mentioned earlier, when you do a large bowel obstruction, because most of these cases are done as an urgent or emergent cases, you don't have a pathology. So I think it's always stick to the oncological principle of resection as much as you can. Obviously, if the patient is hemodynamically unstable, if they're sick, if they're bleeding, you can always, I always tell my patient, you can use this if you want. I tell my patient for every surgery, I say, my number one priority for you is to make sure that you get out of this OR the same way that you get into the OR, okay? Number two, I tell them I have to make sure that I do oncological resection. And then number three is cosmetics and things. So, if you cannot get them out of the OR healthy, there's no point of, doing oncological resection. But in general, you can if you're good at it and you've done it a lot. All attempts should be made to inspect the proximal colon for evidence of gross injury or something. Yeah, you always, if you have an advanced lesion, the risk of having other lesions is high. So you have to check the rest of the colon. And the other things is very common. I've seen this many times where you have a large bowel obstruction in the sigmoid and tear in the cecum. So you have to check these things. You cannot just resect the colon and then leave the rest, because you're going to have another perforation within the next 24 to 48 hours. So this is basically it in the presence, exactly what I just said. In the presence of ischemia, perforation, coexisting lesion, or large serosal injury to the cecum, then you're going to have to resect other areas. And in emergency situation, I don't advise doing two-segmental resection. I'm a big advocate of two-segmental resection in elective. I just discussed a case with a colleague, so I don't want him to think, I lecture different than what I actually do in practice. So whoever is listening now to me, the guy I just spoke to, This is an emergency. I will do a subtotal, but in elective, I will do it differently, okay? Remember, if the patient condition permits, the stoma should be minimized. So I always, I mean, you guys, whoever scrap with me, I'm like, I have to think about plan A, B, and D, and C. So I always mark the patient before going to the stoma, before going to the OR, if I can. The idea is because you guys, and I had this discussion with multiple colleagues, they will tell me, Ahmed, come on, let's just finish. Do the stoma, this is only temporary. We're gonna just, the patient's we're gonna come in 2 months and we're gonna close the stoma. So I disagree, because the way I look at it, sometimes you're gonna do a stoma and you're gonna think you're gonna close it in 2 months, but because of complication of many other reasons, the patient is living with the stoma for 6 months or 1 year. So my rule always is prepare the stoma like it is a permanent stoma, full stop. If you do it this way, then you know if they keep the stoma, they will not suffer. And believe me, if the patient are happy, you will be happy. If they are not happy and miserable, they will make you unhappy and miserable. It's the rule, okay? So I always mark as much as I can the stoma, and we can discuss this later if you guys want about how to mark, but that's what I would do. And remember something, in emergency Hartmann's, for example, over 50%, let's say 50 to 55% of patients don't close their stoma. The literature just shows it. When you do a Hartmann, 50% of your patient, even though you promise them to close the stoma, you're just not going to close it for whatever reason. Either they die or they are unfit and this and this. So this stoma might be permanent. Just remember this. So, yeah, I mean, a lot of the time I have this discussion with the people. I mean, we have a lot of discussion because so people always think because it's an emergency surgery and I did a subtotal colectomy, then I have to be an endoleostomy. I don't understand. If the patient is stable and everything is viable, you can always do an anastomosis. It doesn't have to be a subtotal colectomy with endoleostomy. You can do a subtotal colectomy with a primary anastomosis. Ileorectal, iliosigmoid, whatever is the thing, as long as the patient is stable. So this is a nice summary for you guys so that you have something in your mind. What is acceptable? Let's say if you have a left colonic lesion, what is acceptable to do a subtotal? So if you have a cecal perforation, then you don't need to do two segmental resection. You do a subtotal, and that is an appropriate answer. And probably this a safe answer and the right answer. If you have a synchronous lesion, let's say if you have a transverse colon lesion and you have a sigmoid lesion, you're not going to do a segmental, you're going to do a subtotal. If there's a ischemia of the proximal colon, it's exactly the same idea, and serosal tear in the cecum. Now, this is another concept I get asked about a lot, and we normally skip through. I had a case recently, and I'm not a big advocate personally. Now, some other colorectal surgeons like maybe to do it. I'll tell you my opinion why I don't like it. I don't do it very often, but I will explain it to you. So if you want to use it, I think it's okay. And so let's talk about it. So on-table colonic lavage is another alternative. So rather than doing let's say a Hartmann, because you tell me, Ahmed, the colon is dilated a little bit, there's too much stool in the colon, I don't want to do an anastomosis with a colon full of stool, so I'm going to do a Hartmann. So somebody found an argument against you, which is what? Say, you know what, you can do a lavage, clean the colon, and then you can do your anastomosis, and you're not worried about having a lot of stool and potential risk of leak, especially in rectal anastomosis. So on-table lavage, so I will give you the techniques, and then you guys can decide later yourself if you want to use it or not. So what you need to do, in my opinion, and a lot of people agree, I don't think a lot of people disagree with me, you have to mobilize the both flexure. You can't, I've seen some people, they try to do a lavage and they don't want to mobilize. It's just a mess, okay? So when you mobilize the two flexure, because you want to decompress the bowel from the cecum into your lesion, let's say in the sigmoid, and also you want to bring the sigmoid beyond the abdominal wall because you don't want to contaminate your field with stool, yeah? So you're going to have to mobilize the flexure. Oh, hello? Hello? Did I lose connection? Am I good?
No, good.
Good, okay. So yeah. It says I have weak connection. Okay, let's go back. Jude, if I lose connection, just text me. I don't want to talk forever for no reason. Right? So, where am I? Yeah. So, so that's you need to mobilize so that you can extend beyond the abdominal cavity. You can do an appendectomy so that you can put a large bore catheter. I'm going to show you a picture, don't worry. You'll be able to visualize it soon. Or you use the ileum if you're worried about the cecum. So there's a picture here, okay? So let's talk about, see the picture a little bit. So you understand? So there are multiple techniques to do it, but I think if you look at the true picture here on the left side, basically really that's it. They mobilized, this is not my picture, I borrowed it. So they mobilized both flexure and they brought the left colon up. So it's outside the abdominal cavity. This is, I think, through the ileum potentially, and they're just washing, okay? So if we go back, so you put saline can be used to get the colon. You can use 3 to 6 liters of fluid. Flow can be slow in the beginning because there's solid stool. And then you need to milk a little bit. And that's what I don't like. It's this a lot of milking. And then that's my very important point. If you end up doing this OTL, make sure you inspect the rest of the colon after you do this, before you do your anastomosis, because you might have injured the colon with milking and fluid and everything, okay? I don't want to dive too deep into this, but there are some studies which has been published recently which have shown that the complication of OTL in terms of having morbidity is a little bit high, and there is a little bit of controversy about if we should do it. Personally, I don't want to brag, but really with my experience, and I do little few things like I will clean and I will milk, and looking at the bowel and things, I will actually do the anastomosis and I don't need to wash the bowel. And most of the time I've been okay. Now, I know this is very vague and doesn't help you for your practice. So I think for you, just either use OTL, and if you're not comfortable with the bowel, just don't connect the bowel. Nobody will blame you for a colostomy. Yeah? One thing I do, I've been doing when I was developing my as I do more cases, then you get more experience, yeah? So initially when I don't like Hartmann's at all, and people know. So I tend to do a resection in the worst case scenarios, and then I do a diverting lobulostomy. I just have to find special conditions, like I look at the bowel, health and things. And I've been good with this, with doing this. So I don't like Hartmann's, so I will end up doing an anastomosis with diverting stoma if I'm not comfortable with my anastomosis. But as I said, for you guys, no disrespect, but I think for you, you just have to, I think in the beginning, just do a Hartmann if you're not comfortable, or do OTL, all right? Inflammation, you guys are gonna talk about this later, but it could be from diverticular disease, Crohn's, radiation. If you had an anastomosis from the stricture and you want to dilate, so this basically can cause an obstruction. So an anastomosis stricture can cause an obstruction. And also acute diverticulitis by itself can cause an obstruction. So we have few cases where the acute diverticulitis with little abscess can cause some sort of a colonic ileus and will cause an obstruction upstream. And the patient will have a dilated colon and people panic. But then when you treat them with IV antibiotics and you drain the abscess, the patient opens up. So just remember this. So acute diverticulitis can cause large bowel obstruction, and actually the management here is medical. It's the same with Crohn's. You can get acute Crohn's inflammation. You give antibiotics, some steroids, and they open up, and then you can do your surgery later. Right? And then, as I just talked, what I do is really here resection primary anastomosis, resection primary anastomosis, diverting lobulostomy, or a Hartmann. And it's all about experience and how the patient is doing, how hemodynamics. So I always talk to the anesthesia. I actually, I know a lot of surgeons don't like to talk to anesthetists because they don't want to just talk, because they think they slow them down. I actually always try to communicate with my anesthetist because I want to make sure the patient is stable. So today I had a case, for example, and I communicated multiple times, and I did change my decision significantly because of my communication, even though the anesthetist actually did not talk to me at all. He was just doing his thing, and I just turned my head because I want to make a big decision, and I said, so what's happening here? He told me what's happening, and I changed my management from 1 to 2. Significant change. So always communicate with your anesthetist. Okay, now volvulus, one of the most popular things. So we see this quite often in Kuwait, I think. One case every month maybe. So either the sigmoid or the cecum, most commonly the sigmoid. Basically, it's a volvulus, so it's a twist of the colon around its mesentery. And the sigmoid is acquired, people say it's with age, things get stretched with constipation. It's not really clear. I don't think you care, and I don't care why it happened. It just happens. And you cannot, I don't think you can prevent it because it's just based on long history of chronic constipation, elongated colon, and then you get the twist. Cecal is more embryological, and this is why we don't see it as often. And it's just because of the lack of fixation of the cecum and the ascending colon to the retroperitoneum. So acute presentation will present with, you have a twist, the mesentery is twisted, you're going to have ischemia, and then you're going to have necrotic bowel potentially if you don't help the patient. Now for sigmoid volvulus, you're going to have the bent inner tube or the coffee bean sign. We'll have a picture soon, so don't worry. And the cecal volvulus is the twisted cecum in the left upper quadrant. It's just opposite each other. If you're not going to remember, the bent tube, the end of this bent tube, so that's the bent tube. This end here point to the right upper quadrant if it's a sigmoid, to the left upper quadrant if it's a cecum. And then the double swirl, the swirl sign in the CT scan is very good to identify. I think most of the diagnosis we make is actually based on the CT. But of course, all the surgeons will tell you X-ray is enough, all right? Contrast enema can be used. I don't use it very often, to be honest. So that's it really. So you see, this is sigmoid volvulus because this is the sigmoid in the left side and it's pointing to the right upper quadrant, with the cecal it will be the opposite. And this is the swirl sign. You see it swirls it, like it's like a circle. This is what somebody used, I think, gastrograph and enema. There is a twist and a stricture. And I think, yeah, this slide is not super deal. I've never actually seen a lot of these cases, but they are mentioned in the books. So there's a iliosigmoid knotting, transverse colon osmotic flexure volvulus, and these are actually not very difficult to diagnose, very tricky, huh? And you might end up seeing some inflammation, and sometimes you just have to counsel the patient that if you resect, they might still have other issues. But if that's the only abnormality, you see something abnormal in the spleen, and they always have pain in the abdomen, sometimes you just have to counsel them and then just do the surgery to resect this segment. And these are just, you can read this slide. It's more like science for you. I mean, I don't see these very often. And this is a typical nice picture of what you see when you do your flexible sigmoidoscopy for the volvulus. So how do you manage volvulus? Let's talk about sigmoid volvulus. You're going to do colonic decompression. You're going to go with your colonoscope, ideally with CO2. Now, I know in Kuwait, we don't have CO2. Like in Adan, we only have one scope that do CO2. In Jabir, I don't think we have CO2, but we have now, I think, recently. No, actually, we have CO2 now. But I know other hospitals don't, so I'd rather CO2. Why? Because CO2, the distension is less, and the absorption is fast. It's fast, 15 minutes. With air, it's just too much distension. Anyway, you're going to go in gently, and you're going to try to decompress this twist. And the success rate is extremely high, it's 80%, However, the recurrence is high. That's why you're going to have, after you decompress, it's not just you decompress and send the patient home. You're going to decompress. You're going to put a rectal tube to allow the decompression to continue. You can use a chest tube. Just make sure the end is not sharp. You don't want to perforate with it. And then you're going to bowel prep them in the same admission, and you're going to operate and resect this. And you're going to do a primary anastomosis if they are healthy enough, if they are, forget healthy enough. Actually, this is not a good point. If they are stable enough. The reason I removed this thing about healthy enough. This is a lot of when I get consulted about these cases, a lot of the time people speak to me and they say, Ahmed, we're going to decompress this patient, but they are not very fit for surgery. I think we're just going to decompress and then send them home. And the thing is that, I keep arguing, most of the patients, except for Eastern Europe, Russia and things, they tend to be younger patients, but most other countries, they are actually old. Typical volvulus patient is actually old, does not, maybe it's immobile, have heart disease, COPD. They keep telling me about the COPD and asthma, and that's why we should not do surgery. Most of them, they actually have all these complications. And I still advise you guys to do a resection primary anastomosis. It's simple, it's not very morbid. As long as you can do a primary anastomosis for this patient, it doesn't matter lab or open. If they have COPD and asthma, then okay, don't do it lab, that's an issue. But having comorbidities and being old is not a contraindication to do resection and primary anastomosis, right? However, Hartmann is always an option and you can always do it. It just is difficult, they are 80 years old, they have a colostomy. They just don't know how to take care of it. You have to remember this. People always say, oh, give him a Hartmann. Hey, how old is he? 65, 70, 75. Give him a Hartmann or give her a Hartmann. But this lady's dexterity is poor. They most of the time a little bit confused. Do you think they can take care of colostomy? No. You know? All right. Cecal volvulus. Okay. So it's really simple. I think for cecal volvulus, now if you look at the literature, there is a little bit of discussion about torsion and cecopexy, but it's not as good as resection and ileocolic resection and anastomosis. So I don't advise to do endoscopic decompression because the risk of perforation is extremely high and the recurrence is high anyway. Just go in and do a resection. No pexy, nothing. Just go and do a resection. These are nice pictures from New York of some volvulus and things. You can see it. Just back again for cecal before I go to pregnancy. So again, just to make it clear, that's my opinion, and that most colorectal surgeons I think agree with me. Okay, please, whoever told you that for sigmoid volvulus there are no other option. It's a resection. You can read and go and you can find case report to do everything. You can find case report for anything you want. Yes, there are like a paper about opening the mesentery of the sigmoid mesentery so that adhesions can form so it does not twist again, but nobody does this. So in my opinion, even if you are in the oral boards and you get asked, what will you do next? I'm gonna do a resection. Anastomosis, no anastomosis. What else can you do? Nothing. And if they push you, you're gonna say, I know some people say about broadening the mesentery of the sigmoid. I know some people do pexy. I don't believe that's the right option. I will do a resection. If they are not stable, a Hartmann. If they are, primary anastomosis, easy. With cecal, only resection. I'm not gonna do pexy. Why? Because it's high. We don't do it in my institutes. We're gonna do a resection. Again, we're gonna do a resection. I keep saying because I keep get asked. Volvulus and pregnancy, it's very common, but I have to say I haven't seen a lot of these. Maybe you guys seen, maybe I just haven't been lucky enough. So sigmoid volvulus is the most common cause of intestinal obstruction in pregnancy, worldwide, up to 12.5%. The management is the same, guys, huh? It's flexible sigmoidoscopy. You're gonna decompress, you can put a rectal tube, and then the decision on when to operate, now that's different. Now, you can either do the surgery in the first trimester or the second trimester, I guess, okay? With the elective section delayed, and you do the decompression, I apologize. You do the decompression in the first trimester and the resection in the second trimester. Or, it's a discussion between you and also the gynecologist when is the risk high for surgery or not, but that basically is the recommendation. I haven't done a case, to be honest. So, this is just based on what I've read. Okay, Ogilvie. Very common. Yes, very common. Massive dilatation of the large bowel can result in ischemia and perforation. So it's serious. That's the difference between functional and mechanical. So it's a functional disease. CT scan with rectal contrast is really the most common test that you use to find out that it is actually a pseudo-obstruction, because that's what you want to know, huh? Is it a pseudo-obstruction or is it a real obstruction? And CT with rectal contrast is the best test. So what do you do? It's really simple. It's really medical stuff. So check offending agent, narcotic, typical histories like orthopedics, because there are a lot of narcotics because of the pain from fractures and things. So that's typical story, elderly patient in orthopedics wards. And to be honest, even I know the questions always come as ortho, but most of the cases I've seen are actually in the ortho ward. So it's reality. It's not just case scenario. Okay? So correct electrolytes. Then it used to be colonic decompression, but now with IV neurostigmine, the success rate is amazing. And if you fail the first time, you can wait and then do another time. The only thing you need to be sure is that the patient is in monitored setting because of, they can get some cardiac arrhythmias and things. So that's why what I do, I will actually consult CCU before I give the neurostigmine. I haven't given any neurostigmine in Kuwait, but I've done it when I was abroad. And then if that fails, colonic decompression, I think is appropriate. And of course, if you don't have neurostigmine, then you're going to do colonic decompression anyway. But But why wouldn't you have histamine? You should. Now, very nice point here. No bowel prep, please. Please, no bowel prep, please. You're gonna cause more problems. Minimal air and CO2 preferably. Again, we know why, because it's distentless and get absorbed faster. And you don't need to intubate the cecum, guys, huh? You can just go to the petaflexure and that's more than enough. And the success rate is extremely high, 95%. Now, after you successfully decompress this patient, put your NGT, put your epidural tube, and then bowel prep them to prevent recurrence. So give them some bowel prep, like go lightly or whatever. If you fail, then what do you do? That's really, no, I mean, we always answer the questions of what to do because most of the time we are so successful, huh? It's like 95, 98% success rate. So you early go to surgery, but that's the answer. If you fail, so you either can do a venting cecostomy, and some people do it radiologically. I've never done it radiologically, but I'm just saying. You can do, if you have let's say if you go laparoscopically or you do a mini laparoscopy and you see a necrotic bowel in the right side because of this, but the rest of the colon is normal, just do a minimum resection. Leave as long Hartmann as you can, so it's much easier for you to anastomose. Of course, if the bowel is all necrotic, you're gonna do a subtotal colectomy. So it's really, there's no one answer to how to manage a failed Ogilvie. It's really about step by step. You go in, you have a look, and then you vent or you resect a little bit. Whatever looks abnormal, unhealthy. So that's it. Right? So these are the, I think the most common causes of, I think, for large bowel obstruction, and the most common ways to manage them. Now, do you guys you're gonna ask me questions, or do I just go to the questions?
Okay, so we got a question from the panel. Wait.
So I have to look at the question and answers? Where do I go?
I will let you know about them.
Okay.
There was one question in the chat, actually, about Hartmann procedure. That it's being a surgeon preference or any clear indication for Hartmann?
Yeah, I mean, as I said, so I don't like to do a Hartmann because I think, I mean, sorry guys, I say this all the time, but that's true. I think the answer of how to manage colorectal emergencies is different between a colorectal surgeon and a general surgeon. So for a colorectal surgeon, I think for us, with the experience, you can get a sense of how to manage dilated bowel with a lot of stool. And then I don't do Hartmann, almost I never do Hartmann. The only reason I will do a Hartmann, if I don't have time to do an anastomosis, that's the only reason. It's because anesthesia is telling me this patient is crashing. So I will do a Hartmann and then I will just close. Otherwise, I almost always do a resection, a primary anastomosis, and a diverting stoma. There's actually a paper recently, I think from DCR, which actually the title was really, I smiled when I was reading the title because it's a couple of papers and they all say, basically, are we talking now in an era where the Hartmann procedure is dead? Because all these surgeons are trying to look at the literature and they've seen that when you compare Hartmann to resection of primary anastomosis with diverting stoma, there's no significant difference. With the diverting stoma, you're going to be able to close it. Most patients close their stoma when it's the diverting stoma versus a colostomy. So that's from a colorectal perspective. Now, if you tell me, Ahmed, I'm just finished my board, now I am the senior, and you know what, I want to make sure my patient is okay, I don't feel comfortable, then I think it's okay. You can always do a Hartmann when you're not comfortable because either there's a lot of contamination. If we're going to talk about what the old book says, so I will tell you now. So I would do a Hartmann as a general surgeon if there's a lot of stool contamination, if the bowel is disproportionately dilated compared to so the colon that is proximal to the lesion is so dilated that there's a discrepancy between this colon and what you're going to anastomose to. Because you don't want to anastomose a small rectum to a large colon. It's just the anastomosis won't do very well except with special techniques. So what I would say, if it's a extremely dilated colon full of stool, if there's a lot of contamination, if the patient is pressors and levo, unstable, bleeding, all these things, I think it's really okay to do a Hartmann. It's just my advice. If you're going to do a Hartmann, please don't mobilize more than you need to, because it's fun to do. Because if you mobilize, if you're going to close the stoma in the future, or you send it to me to close it, I'd like to see some fresh planes to start my procedure rather than you destroying all the planes. It's just fun and easy to do because you opened your big laparotomy, yeah? So that's it. So these are the rules of Hartmann: sick, contamination, large diameter of the colon. I think it's okay to do Hartmann. So I think there's a surgeon, just to answer you, I think there's a part of it is surgeon preference, but part of it is also confident and making sure the patient is safe.
Stable. Yeah. Okay, thank you. So we have time to go over the questions, 5 questions of the PowerPoint, the initial 5 questions. We can just go over the correct answer, and then we can go over a bunch of questions from the chat. So let's start with question number 1. Where was a 48 years old male patient present to your ER with obstructing sigmoid mass, a staging CT of the sorry, I lost my video.
Okay.
It caused dilated colon up to the cecum with no small bowel dilatation, lung and liver mets. So what is the best management option? So the correct answer was...
So, okay, so I just get the text from somebody. Let me go back.
Sorry,
so
okay.
staging CT of the sigmoid mass causing dilated up to the with no small bowel dilatation. Yeah.
Yes.
So
yeah.
Do I say the answer, or you guys say? So the answer, I think here it's reasonable to do a stent. Why? You have a young patient. You have a young patient. The colon is dilated, but the small bowel is not, which means that they have a competent ileocecal valve. But they are stable. Huh? I didn't say anything that they are unstable, so I think you can stent them, and then you can bowel prep them appropriately, and do your surgery potentially electively later. So that's what I will choose. Or you can refer to me as a colorectal surgeon. I think these are the appropriate answers.
Okay, so question number 2. We'll give them a minute to read it and answer it, and then we can discuss the answers. 48, this was question 2. 48-year-old female present to the ER, and the CT showed a rectosigmoid mass. It was causing a dilated colon up to the cecum with a mild moderate free fluid. In the OR, you note rectosigmoid mass with colonic dilatation and tear in the cecum. Identify liver mets. The best management option is... So we'll give you a minute to look over the answers so we can discuss the correct answer. Is it A? Okay. We'll give them a minute here.
Okay, so the answer is, sorry. So the answer is, that's the controversial, because that's every time I do. So what I would do B. Okay, and that I got criticized by people, but I think, touch wood, my patient, they go home, so it's okay. I mean, they can. So the idea, I think you can do both. The way I look at it is this way. So the question is simple. I made it very simple. I said the patient had dilated colon up to the cecum with a tear. Okay, so now I know I'm gonna do. We have a criteria in the slides, and we said if there is a tear in the cecum, you are allowed to do a subtotal, and maybe you should. So I did a subtotal. Now there's only free fluid. I didn't say there's stool contamination. I didn't. Now you have very nice ileum. That is it distended? No, it's not even distended. And you have a rectum that is already decompressed. So actually they match each other very nicely. So the patient's stable, and he's 48, man. Sorry, she's 48. Come on, and she's young. You're gonna put them with ileostomy? Why? Just do anastomosis. Ileorectal anastomosis is one of the strongest anastomoses. Like for me, when I counsel patient, actually, when I do a left colectomy, I'm more worried about my anastomosis than ileorectal. Now, yes, ileorectal anastomosis has its own disadvantages because you're gonna have more bowel movement, and they can suffer from the bowel movement. I've had cases where people begged me for a stoma because they go to the toilet 10, But, subtotal, you still have a segment of sigmoid and long rectum. So I don't think you is as bad as only when you do mid-rectum, ileo-mid-rectal anastomosis. I think it's like a disaster. So for me, I would do a subtotal with ileorectal anastomosis. whoever answered colectomy and endocolectomy, this is definitely wrong. And I wouldn't do two, as I said, I don't do two resections, yani. I don't do two resections for emergency surgeries in general. I will do, yeah, in general, but as I said, there are always exceptions, and I do stretch the boundaries every now and then for myself to, just because, I mean, there are, you know, other criteria for, but in general, I will do subtotal with ileorectal anastomosis. But subtotal and subtotal colectomy with ileostomy is okay, guys. You can also do. Or refer to me. Very nicely, 14% refer to me, so it's good.
Next question. So question number 3, we can read the question. You can read it and give them 1 minute to discuss. And when the results are up, we can discuss the results. Yeah.
So 55 years old, female patient present to the ER with a sigmoid volvulus. She's hemodynamically stable, huh? She's stable. What do you do? What did I want to do? Okay, chronic. Yeah, we talked about this just like a few slides ago.
So we'll give them 1 minute, and when the results are up, we can discuss the correct answer. Okay, so everyone put his answer, his choice.
So the answer will be, so as we mentioned, we said, yeah, so exactly, the majority of people, so it's good. So my lecture has been useful. So I will, at the same admission, yeah. So I will decompress and I will do the resection same admission. If you send them home, they will just come back with another valvulus. And most of them, they don't come and follow up anyway. So I would keep them, bowel prep them, and then operate. So perfect. So that's what I would do. I wouldn't do any of the others. This is simple, yani. All right? Or refer to me. I don't mind.
Okay.
Okay. So question 4, again, this time the same lady comes to the ER again, stable, but this time with a cecal volvulus, okay? So what would you do? Same thing. Sorry, not the same thing. It's the same stable patient, but cecal volvulus rather than a sigmoid volvulus. So the answer is, do I mention it? Okay. So the answer is, okay. So exactly. Perfect. So I mean, no. I mean, we just, it's easy. You know, we don't need to make it, don't make it complicated. This is a cecal resection. Model. Okay, good.
So this to answer also one of the questions, one of the attendants were asking, which type of volvulus that only we do resection and no, there is no place for big C. This is the answer.
All resection there, all resection. Don't even because all volvuluses, all of them need resection. All of them.
Yes.
It's just simple. You know, as I said, you can always go to the literature and you can tell me, Ahmed, come on. Yeah, and what if I don't want a resection? Okay, there is of course big C, but you know the recurrence is high, so it's not almost never the right answer, regardless of the patient age and comorbidity. So for me, regardless of the patient, I will tell you now, I will never, if the patient is not fit for resection, then I will not do a PECSI. I'm not going to even operate. Khalas. And it's either, so they're not fit for general anesthesia. I will never do a PECSI, and I don't think you should. So, okay.
Next.
Okay, question 5. So 65 years old female patient, you are seeing at the orthopedics floor for the management of what seems like a Ogilvie syndrome. She's hemodynamically stable. electrolyte has been corrected, but then still the patient did not open up. So what would you do next? Okay, so 1 minute.
So this is a tip for the resident. When they are telling you in the question that she's stable, electrolytes correction failed, and they are telling you what is the best management. So always pay attention to the format of the question.
Yeah. So it's been a minute. So basically, as I said, we're going to give the neostigmine exactly. And so you're going to give 1 shot of neostigmine. If it does not work, you give another shot. I think after the second one, it does not work, then I will go with coronary decompression. So 2 shots of neostigmine in monitored setting. You have to say this monitored setting, CCU, ICU, whatever you have monitored. And then if it does not work, then coronary decompression. But believe me, neostigmine is magical here. It's like magic. Huh? It just boom, opens up. Right? Okay, now we're gonna go. I think that's basically what's yeah.
Yeah, now we have 3 questions from the Q&A.
Questions.
Just quickly, just 3 questions. So we already answered the question about which type of volvulus to be fixed, to be resected and not fixed, it's cecal. Dr. Sleiman Mazidi asking, who did the first robotic cholecystectomy in Kuwait? Yeah, yeah.
Me and Dr. It was a combined effort between me and Sleiman, both of us, combined.
Yeah, yeah. So another question about what do you recommend to use as a rectal tube after endoscopic decompression? I think you answered this about chest tube.
Well, hospitals, at least in Adan, I know we have a rectal tube. In Jabal, we have a rectal tube. It's just called rectal tube. But if you don't have one, use a chest tube, but make sure that the sharp end is not the one is going through. And if you just can, you can unsharpen it. It's just you don't want to perforate it. You want to just guide it and just beyond the volvulus. So that's what I would.
Good. Okay, so we can go quickly over the case scenario.
Okay.
Just for yeah.
So how are we going to do it? Because unfortunately, the R5s are lucky because normally there's one R5 in the corner and I just ask questions. So since we don't, we're going to basically, you guys, I have to put the chat you told me and then they will answer. And so
we'll try to keep it simple. Just to give an idea to the audience about the case scenario, how it may present in the exam.
The lecture? Sorry?
Like quickly, we'll go over like whoever answer first or like a simple question.
Yeah, I will just give them like a few seconds, put answer, and then there's no answer, I'll just tell them the answer. So
yes,
I go to chat. Okay,
we'll give them
chat.
time.
Okay.
Yeah.
Okay, so let's start. So you have a 65 years old patient. As I said, guys, just so that you concentrate, this question might not be related to the lecture. So you don't need to think about volvulus and colon cancer if the thing is about hemorrhoids. So just so that you know, you don't need, it's going to be, this question is just useful for you because I think we talked enough about large bowel obstruction. I think we really like squeezed it so much that I'm not sure there's a need to go through it, okay? Again, so case 1, 65 years old male who presents to your endoscopy suite for colonoscopy because they have a history of a rectal bleed. So how would you proceed? Now, because this is not as I expected, because I thought I'm going to talk to somebody, I will make the question simpler. So you go, how do you proceed? So what I would expect you to say in your oral exam, you're going to tell me, I'm going to take focus history, and exactly, focus history, clinical exam, and then I'm going to talk about the risk and benefits of this colonoscopy and what I'm doing it and what are the risks of colonoscopy. So what I like to tell my patient, the risk of perforation, 0.4% or 2 in 1,000, risk of bleeding, if there is a polypectomy, about 2%, if there is none, it's much less, and these things, you know. Then I'm gonna then tell them because you have bleeding, where you are 65, you never had a colonoscopy, so I'm going to check from the history if they had colonoscopy. Then I'm going to do my colonoscopy, okay? So the question will come is how you proceed. You're going to do your colonoscopy. Let's see the next slide. Okay. So you encounter a pedunculated 1.5 centimeter polyp. What's your next step? So you're going to tell me what would you do. So you are faced with this now pedunculated polyp. How are you going to, I'm assuming you want to resect it. So how are you going to do this? Exactly. So you're going to snare it. So you do the snare. It's 1.5 centimeter. I think biopsy is not the smartest answer. It's 1.5 centimeter.
I like this question. We can have someone, I like this question. We have someone from the board. We have with us usually we have Sarah Safi and Fahd Saleh, R5.
Okay, so I'm looking at the
they
answer.
Don't mind, yeah. Pick someone. Yeah. We can actually ask them, like, if you want, you can choose someone and to ask.
So let's do it, because that's the question. I formed it so that they chit chat with me.
Yeah,
so they can access the audio.
We have Dr. Sarah Safi and Fahd Saleh with us. So we can start with Dr. Sarah. She actually answered polypectomy.
Okay, so you do a polypectomy. So my Sarah. Okay.
Sarah.
So Sarah is what? Is what?
R5.
Well, I know Sarah, but I don't remember which. Okay. So so where are we? So let's go now back to examination mode. Okay. So pedunculated 1.5 centimeter in size. What's your next? Okay. So you're gonna do a polypectomy. Okay. So you do your So Sarah, you do your polypectomy, and now there is bleeding from the base. So you decide to do a cold snare. You did not use a hot snare for whatever reason, which is fine. But you decided to go with a cold snare, so you did not use energy. And you resected this polyp, and now the polyp base is bleeding. How do you proceed?
So I'll try to find any adjuncts to control the bleeding. Hello? Hello?
Hello, yes, I'm listening. Okay, so?
Yes, so if I have any clips, any injections, to control the bleeding.
So the way you have to answer, you have to tell me. So I'm not going to be extremely examination, anal about how to answer, but I'm going to guide you. So you're going to say, now you are in the situation, you're going to say, I will ask for, and then you tell me, what did you want? Not look for,
I will ask for clips, endo clips.
Okay. So you take clips and you apply it, and it still does not stop the bleeding. What other things can you do?
I will ask for saline injection or adrenaline injection.
Why do you want how saline injection is gonna?
Sorry, adrenaline injection.
So epinephrine, you mean? Okay.
Epinephrine, yes.
So what's the concentration of epinephrine you're gonna use? I'm not sure. When I was it's 1 in 10,000. I didn't know the answer when I was asked, so I'm just. But some people want to know. Anyway, it doesn't matter. It's 1 in 10,000. What else? So you try epinephrine injection, it does not stop. What else do you have? Give me your armamentarium. What do you have in your armamentarium to stop the bleeding?
As hemospray, if I have our spray.
Yeah, hemospray does not work. So other options you have, okay. Sorry, tell me.
argon.
Okay, so you tried injection, you tried injection, you tried epinephrine. Let's say if you're trying to inject the epinephrine, but there is a lot of bleeding, what ways can you do to allow you to visualize the base?
So I want to elevate the base. So inject saline underneath it to elevate the base. And visualize if there's any vascular bleeding or any obvious vessel that's bleeding.
Okay, so your colleague comes to assist you, and what he does, he actually asks for a water jet so that the clots and the bleeding that is covering the base, you can see it. And then he asks for a heat probe, and he stops the bleeding. Okay. And then now the bleeding stopped, and you're happy, and you apply extra clips, and then everything is fine. Now you discharge the patient, and then the patient comes back to you after 1 or 2 days, let's say 24 hours, with abdominal pain and fever. How do you proceed?
So I'll start with history and physical examination.
So history is the same history, physical exam. He is tender, and he is telling you he's having fever and chills. So what's next?
I will send for lab investigation, CBC.
Okay. So you do your lab, and the lab shows that the white cell count. Yeah.
Sorry, white cell count
is 13.
13. I will do
a
chest X-ray to check if there is any evidence of pneumoperitoneum.
So
if there is nothing, I will proceed.
So you asked me, so I'm going to answer you. So there is a thing. There's no nothing. So there is some air under the diaphragm. So, and the patient now is becoming unstable. What would you do?
So I will say he's in the OPD setting, right? In the ER. Okay. So I will insert 2 large bore cannulas, give him fluid resuscitation, 1 liter normal saline, insert Foley's catheter, send the blood for grouping cross-match, consult the ICU on call and the anesthesia on call to prepare the patient for laparotomy.
Okay. So you do that, and the patient is stabilized, and you go to the OR, and you find a 1 centimeter hole in the sigmoid where you did your polypectomy. What are your options? What would you do?
So, depending on the viability of the tissue, then my options are either primary repair or resection and anastomosis or diversion. Repair with proximal diversion.
So you do diversion alone?
Primary repair of the injury and proximal diversion.
What else? What other things you guys are keeping asking me about and you like it a lot? What's the other option? Hartman. You guys asked about Hartman.
Yes.
It's an option, yeah. Okay.
Yes.
Excellent. That's it, I think. Yeah, let's see, make sure that there's nothing else. Okay. So you did very well. That's it really. It's really simple, but that's a common scenario. So, you have to know what are the techniques you have to do a polyp resection. So there is something called hot snare, cold snare. My advice always, if the patient is on aspirin or if you end up doing something on Plavix, which you should not, but any anticoagulation, if you do hot snare, reduces the risk of bleeding compared to cold snares. And I forgot the size. I think it's if the base is over 5 millimeter, if the base is over 7 millimeter, the risk of bleeding is higher with the cold snare, so you should use a hot snare, I think. Techniques to control bleeding, you have to know there is clips, there's epinephrine 1 to 10,000 concentration, heat prop, you can use hemospray, which is useless, but you can, it's okay to mention it. Water jet is very helpful to allow you to actually visualize the bleeding point. You can inject, I don't think you used to use saline, because you're just putting a needle with useless stuff and you're making more punctures. So I would just do epinephrine, water jet. You can reposition the patient from right to left and the blood will move away if it's, in a way, so maybe the polyp will go up and the bleeding will be down and then you can inject. So changing patient position is one of the other techniques besides water jet and heat prop and epinephrine and clips. And then exactly what you did, perfect. The patient is sick. You did not forget that you need to resuscitate. I loved what you just said. I'm going to resuscitate. I didn't push you out. A lot of people just tell me, I'm going to the OR. They didn't resuscitate. They didn't consult anybody. So you did very safe, very nicely. And then you went to the OR and your options are excellent. You did a resection anastomosis, primary repair if it's very small. And I think you did very well. Okay. So next one, who wants to take the next one?
We have Fahd Saleh ready.
Okay. So, Fahd معاي with me? Okay. Okay, yalla. Okay, so we'll start. What is this case? It is about, okay, I like it. Okay, good. All right, so this is a 50 years old patient, male patient, comes to you with a rectal bleed. Oh, I already showed you the slide. Okay, so what would you do? Rectal bleed? Let's make it faster, so you don't need.
Okay, so yeah, so we'll begin with a detailed history and checking about the bleeding. When did it start? Is it with the defecation, without defecation, associated with pain? And how long has it been? Is it bright red, or is it mixed with stool, or is it dark?
Okay, so you're going to take a focus history about the presenting complaint, and then what else you want to ask besides the presenting complaint?
Any previous abdominal surgeries, any history of malignancy, if he has done a colonoscopy before or not.
Nice. Okay, so no colonoscopy in the past, no malignancy in his family or himself, and no surgeries in the past.
Okay, and then proceed with the local examination of the PR area.
So you examine him, abdomen is okay. You are in the clinic, huh? So no labs, abdomen is okay. You do a digital rectal exam, nothing really. Then you do with an anoscope, you find some hemorrhoids. And then the patient now remembers he actually had a colonoscopy. And he told you it was normal except for hemorrhoids, okay?
When was the colonoscopy done?
He also tells you that he already, you're gonna tell, he tells you, what, please doctor, don't tell me take laxatives and fibers and sits bath. I've already tried these and there's very little improvement. Okay, he already closed the door for you to just بالعربي تزحلقه تقول laxatives ودافلون نروح البيت. No, it's not going to happen. He already tried it. He's coming to you now and he wants something else. So what other options do you have? He tried for 7 weeks. What I tell my patient. Failure of medical treatment is decided if you try all the conservative management with medication for 7 weeks. So he is now at 7 weeks and little improvement. What's next?
So, well, we can consider.
Hello?
Hello, do you hear me?
Yeah.
Do you hear me?
What? Yeah.
Yes, so if conservative medical management failed, then we can consider surgical treatment in the situation.
So you will take him for a hemorrhoidectomy?
Yes.
Okay. So you start your consent. So what would you tell him about the hemorrhoidectomy? Can you tell me what would you tell him?
Yeah, so it's usually done in an examination under anesthesia, whether it can be either general or under local spinal anesthesia. We will do a focused digital rectal examination with a proctoscopy.
So he asks you specifically, he will be more specific, and he will ask you, he says, so how many hemorrhoids are you going to take?
So preferably just remove the hemorrhoids that are in concern, maximum 2. To try to...
Let's say there are 3 in concerns. Large, big, juicy.
So the concern is that if all of them are removed, there will be a large raw area that might cause anal stenosis in the future. So that you have to have normal skin bridging between the areas of resection to prevent anal stenosis. So we'll try to preserve the as much skin and mucosa as possible and only remove the ones that are pathological.
So somebody mentioned stapler hemorrhoidectomy. We can talk about it later. Remind me, but let's go. Okay, so I'll tell you what. So you tell him, you tell the patient, I'm going to do 3/4 hemorrhoidectomy, but I'm going to leave the bridge because I'm worried about the stenosis, okay? So he hears the word stenosis and he gets anxious. And he tells you, what? Stenosis? And he will then ask you, what are the complications of doing a hemorrhoidectomy? What would you say?
So the complications can be local infection and abscess formation, could be post-operative pain. There might be anal stenosis. There might be bleeding as well, and these are the main local.
So he tells you, you know what, doc? Come on, man. He tells you, come on, stenosis. I've lived all my life with these hemorrhoids. Now you're going to tell me stenosis. I heard also there is incontinence risk. And you know what? Come on, there's nothing else you can offer me other than going to surgery immediately. What would you say?
So there are other alternatives such as ligation of the hemorrhoidal arteries.
Okay. But he said, come on, doc, come on. He said, doc, please think. I don't want surgery. Is there anything you can do in your office now? I want now.
So banding, hemorrhoidal banding.
See, okay. So it tells you, okay, I'm interested. So you have banding. Anything else, doc, besides banding you can offer me in the clinic?
We can do sclerotherapy injections.
Okay, so which one I should do? Okay. Let's say if he tells you, okay, doc, I like both. Forget surgery, please, let's concentrate on this now, what we can do today. I have somebody who can drive me home, so don't worry. Now tell me, which one should I choose? Let's say if the hemorrhoids are, I don't like to use a grade, but I'll give you a grade, let's say grade 2, and you have, let's say, 2 juicy, not 2 symptomatic hemorrhoids. Let's say 1. No, let's make it 1. Now, okay. Which one would you choose? You're going to use banding? You're going to offer banding? You're going to offer sclerotherapy?
I would offer banding.
Okay, so he tells you, okay, let's do it. So you do banding, and he tells you, so you put the band, and then suddenly he has severe pain. What would you do?
So if the patient has severe pain, immediately. So I would try to remove the band, if not possible, during in the clinic.
But how do you remove it? Technically, how can you remove it?
I would best to do it in the main operating theater under an examination under anesthesia, with the removal of the band with using forceps and scissors, and just cutting the band open.
So you put the band and the patient is shouting in pain. Then your colorectal colleague tells you what's happening. You tell him, I just applied the band.
Yes.
And then he tells you, what are you doing? You say, I just called the OR to book him. What he does, he wears double gloves. He put his finger through, and then he just pulled the band. And the patient now is not in any pain anymore, okay?
Okay.
So he does this, and the patient is doing okay. He goes home, and a few hours later, he comes with a fever and urinary retention to the emergency room, all right?
Okay.
How do you proceed?
So I would proceed initially with, my full examination, simultaneously assess and resuscitate the patient if needed. Will place 2 IV bore cannulas, send the routine labs and cross-match, and do a septic workup, including blood, urine, cultures, and we will do our abdominal and local examination. And
abdominal, so the labs vital count is 17. The rest is okay, I guess. As CT, sorry, his abdominal exam shows like some tenderness, suprapubic. Perineal exam, he's in pain. There's some erythema maybe around the scrotum, but that's it. Around the perineum, I mean the scrotum. So what's your next step?
So I would do a CT of the abdomen of the pelvis to rule out any pelvic.
So you do a CT. There's would IV contrast or no contrast?
I would give IV contrast.
So CT shows no collection, some air in the perineum area, gas bubbles, basically air.
And
so what would you do next?
And in the examination, there is no crepitus in the local examination in the area.
Because it's tender, uncomfortable, he's obese, I forgot to tell you, not very easy to visualize.
So I will counsel the patient and will consent to them for a operative assessment, examination under anesthesia for possible incision, drainage, and debridement, depending on the finding of what we see.
What are you worried about? What's your first number 1 differential? What are you worried? What are you dealing with?
The main thing I'm worried about is necrotizing fasciitis, given the presence of air. And the patient.
So what would you do besides taking him to the OR? Anything else you want to give before I go to the OR?
So we will start the patient on broad spectrum antibiotics, pain relief, painkillers. I will
So you take him to the OR and you do your EUA, and what you're going to do, you see a lot of necrotic tissue, let's say around the perineum and the anal verge area. but the rectum relatively is okay. So you're gonna do what? You're gonna debride.
So debride until I reach healthy tissue. So
then,
I will
So you
excise.
do this, and it's done, and now it's healthy. What's next?
So once it's healthy, I will pack the wound, preferably transfer the patient to the ICU for a second look and for reassessment, and resuscitate and control the sepsis. And then on following reassessment of the wound, depending on the outcome, we'll consider whether the patient is a candidate for primary closure, vac therapy, or grafting if needed.
Okay, let's say if you're worried about that the wound is very deep. Yeah, tell me.
Yeah, I will put a rectal tube to divert the stool away from the.
Any other options you have in your armamentarium to divert the stool?
We can do a colostomy, a diverting colostomy.
Okay, good. So that's a common thing that you have to know how to manage complication of banding. Now, I think you started very well, history exam, very nicely, but definitely it's a mistake to go to the OR directly. It's unfair, you know? And unfortunately, I think the reason we do this is either because we don't do bands in most of the hospitals, or I don't know why. It's just, you're not the first guy. Everybody wants to do hemorrhoidectomy. Imagine, you know, I work relatively hard in my clinic, but if you look at the list, I'm the least guy who do sphincterotomies and hemorrhoidectomies. And I see some other people, they tend to do it a little bit more frequently. I guess my threshold is a little bit lower for reasons, because I've seen the complications of hemorrhoidectomies and sphincterotomy. And because I know that patients in Kuwait, they tend to be very demanding and they put pressure on the surgeons. But I think, and we don't have time to actually explain to them why we don't want to do the surgery and things. Most people, if you explain to them the complication. So when you told me stenosis, when you tell me all this, I will push you for other options. I'm worried if you tell me there's a risk of incontinence, you know. So always think that you have other options, and they work very well. I tell my patient, if I do a proper banding, I will give them a guarantee, like a warranty, for 3 years to 5 years. That's how confident I am that banding works. It works very well, the banding. Now, sclerotherapy is not as good. And my tricks always for sclerotherapy is that I use it for patients who have anticoagulation, because with banding, if the patient is in warfarin, you should not do banding. But sclerotherapy can be used in patient on anticoagulation. I use almond oil. You can use peanut oil, whatever. I do my own mixture. I can, you know, if you pay me, I'll give you the recipe, but that's what I use. I've used it in a couple of people on warfarin, and they didn't come back. Now I don't know if it's worked or not, but they didn't come back. So I'm assuming they're doing well, because they needed to do like cabbage or something like this. Now I pushed you toward banding, and you did the banding, which is fine. And banding success rate is better than sclerotherapy. So I think what you said is reasonable. And then you need to know what I counsel my patient. I really do it. I'm not just telling you this in a lecture. I do this every clinic. That's why I tend to be a little bit late I spend too long with patients, even for hemorrhoids. Because when I do the banding, I will tell the patient, number one, the first complication, you can get vasovagal attack. And that's why I don't do banding in the first visit, because I want the patient to have somebody who can drive them home. And I will tell the patient to wait in my reception for another 40 minutes to make sure that they don't collapse. So vasovagal attack is 1. 2, they can get bleeding post-banding. And I tell them the bleeding tends to get better 2 to 3 days if it does not come to the ER. And 3 is sepsis, exactly. And you can get sepsis. I've never had sepsis myself, but my colleague did. And exactly, then you did very well. You took them to the OR and you did your debridement. And I liked that you were hesitant to do a diversion, because I don't think you need to divert everybody. People call me to ask for my opinion about this. And I think if the wound can be maintained well, I'm not sure about rectal tube, to be honest, because most of the time they don't work very well. But I think if the patient can maintain themselves and clean themselves well, and they have good wound care, maybe you can do the stoma later if it fails. Let's say if you cannot, and forget about grafting and things. Did this to the very late. But, you know, I will only do stoma in my second setting most of the time. I only give it, you know, nobody's going to die within 24 hours after the debridement because you did not divert them, So I will give them 24 hours and then I will divert. Or 48 or 7 days or 3 days or whatever. So that's it. I know we still
perfect. Thank you so much. It was a really nice lecture, a nice question.
There's still one, You don't want the third one? There's still one.
Do we have time? Let me check.
It's okay if you don't have time, to be honest. It's fine. I think we chit-chatted too long.
The issue is we don't have more participants. The other R5s are busy and on calls. Sorry. Let's see. Anyone ready?
Yusuf Al-Eid, but I'm here.
Okay. Yalla, Yusuf Al-Eid.
Okay, this is a little bit difficult, huh? So prepare.
Good. He can do it.
Okay, so about the hemorrhoid, just to talk very fast, I know it's too late now. About the stabular hemorrhoidectomy. Now, full disclosure, I'm biased.
Okay, good evening, Dr. Ahmed.
هلا بس خليني ارد على الستيبلر هيموريدكتومي. خليني اقول ماي اوبينيون دقيقه. الستيبلر هيموريدكتومي I'm biased against it. I don't like it. I don't recommend it to a family member. I think only people who do stable hemorrhoidectomy regularly, weekly, like the Italian guy who keeps coming to wait to promote it, he is maybe one of the few guys who should do it. Other people, I don't think they should do it. The complication is, when you get the complication, it's scary. I've seen a lot of people to vaginal fistula because as somebody only doing this case, doing once a month. Hello? دخلتوا عليه. الو
شو المشكلة الصوت؟
لا اوكي عليه في صوت شيء anyway بس فهذا my biased opinion. Sorry, I will not do stable hemorrhoidectomy and we can discuss it later. Let's go to the last scenario. So 18 years old, female patient, come to your clinic complaining of what she calls like a skin tag. She thinks it edematous, and she wants you to have a look at. So you bring her in, and you see multiple skin tags, and you notice a fissure in the right lateral aspect. Okay. Hello.
Okay. First thing, I will introduce myself. Then I will introduce myself first. Then I will take more history about the patient. Since how long she have this skin tags? If she have been
just a question. The audio is okay, or
yeah?
Okay.
For me, it's okay. Yeah. Hello.
أنا أسمعك. كمل انطلق.
Okay. So I will take more history about the patient regarding the skin tags, how long she have it, have any associated symptoms, constipation, mucus discharge, bleeding the rectum, any.
So you take more history of presenting illness.
More history, yes, yeah.
Okay. So what else besides? So you said bleeding per rectum. Anything else you want to ask about?
Yeah, if she have any. With history, patient, if you have any like abscess ulcer in her mouth, any change in bowel habit. Also, I will ask her about her if she's married or not married.
Why do you want to ask her married or not married?
Because I want to ask about her sexual activity. Is it protective or non-protective? Also, I'll take history about if she have like family history of IBD, like Crohn's.
Okay, so she gives you a history. So she tells you she has a family history of IBD.
Yeah.
She tells you she has a family history of incontinence. But from her perspective, she had for 1 year intermittent diarrhea. Normal continence, and when she wipes, she had bleeding and pain. She tried some dietary modifications and stuff, but really no help.
Okay. So
what's your next step?
I will think first loudly what's my differential diagnosis for this patient. It could be implantable disease. It could be like sexual transmitted disease like HPV. It could be trauma. So first thing I will do for her.
What's your next step? What would you do next?
I will do an upper and lower GI endoscopy.
Okay.
Before I start, I will take full lab investigations for complete blood count, renal
She's
function
in
test.
remember, she's in your clinic now, huh? So you're gonna book her for a colonoscopy and gastroscopy, and you're gonna send some labs.
Yeah.
And while
Yeah.
she's waiting for you to deliver these things, what are you gonna do to her?
I will just give her some instructions for lifestyle modification. I give her some laxatives, and also I will give her some topical treatment.
Like what?
Like topical NSAID, like a xylocaine gel for the pain management. Also, I will advise her to have a sitz bath. And I'm considering to take a biopsy from one of the skin tags.
Okay, so you're gonna do it in the clinic.
I prefer to do this skin biopsy after result of colonoscopy and endoscopy.
Okay. So any other medical treatment you're gonna offer her while she's waiting for the appointment next Thursday?
I will consider to give her calcium channel blocker topical.
Okay. So you do this. So you do a laxative, sitz bath, dietary advice again, and then she comes to you. So you do a colonoscopy, and you find. So you're gonna do a colonoscopy, and you find upper GI is okay. Colonoscopy, there's some ear inflammation. You take biopsies, I assume, and it comes back as suspicious of IBD.
Okay.
Any other tests you want to do to complete the IBD workup for this patient?
Any other tests for this patient?
You know what? Sorry, it's suspicious for IBD. There's no granuloma, but it's suspicious for IBD. It does not say IBD.
Okay. I can do examination under general anesthesia.
Okay.
Okay.
So you take the examination under anesthesia.
Yeah.
Because, I'm assuming you're going to do only this because she tried the medical treatment and it failed miserably. Yeah. There's no improvement. You waited for 6 weeks and still there's no improvement. She's still in pain. She's suffering. And you said, you know what, 6 weeks is more than enough to consider medical treatment to have failed. And since I'm suspicious of IBD, let's take her to the OR. So what are you going to do in the OR?
First thing, I will position the patient. I will give some bowel prep, at least for glycerin substrate to empty the rectum. And I will consult the patient about the procedure and what I will do during the procedure.
What are you going to do in the procedure?
I will do an examination under anesthesia with lithotomy position. And I will inspect all the anal area. I can take a biopsy from the skin tag.
You see the same things that you've seen in the clinic?
Yeah.
So I tell you what, so you see exactly the same thing, nothing new. Fissure in the left and the right lateral and skin tags, nothing different than what you've seen in the clinic. So what are you going to do?
So I will try to take a biopsy from the skin tag, and I will consult. I will take opinion from my colorectal surgeon as present, because I haven't seen.
I like it. I like it. Okay.
Yeah, I haven't.
So your colleague tells you, you know what? You just did not give me the tickets for the Champions League final, so I'm sorry, I'm not going to answer you. You are by yourself.
Okay, I will take biopsy from the skin tag area from the anal fissure.
Okay, so you do this and comes back as granulomatous Crohn's disease like. So what's next?
Yeah. The next step, I will first thing I will prepare this patient for an GI team colleague, a GI colleague, for consideration to start her on some medical treatment, and I will assure the patient that she have on this chronic disease. She's not candidate for an surgical intervention.
Like what?
Because like lateral sphincterotomy.
Why? She will ask you why. She said her friend has sphincterotomy. Within 48 hours, she was in the best condition of her life.
Because her pathology is different than her friend. As a patient, her friend, she have an inflammatory process like muscle spasm in the anal verge, and she have a different pathology that would have high failure rate with more complication regarding like wound infection, incontinence.
That's good. Okay, so let's say she tried all the medical treatments, and now she tried biologic and everything, and now her colon and small bowel is perfect. There are no signs of IBD, but this fissure is not getting better. What would you do to it? Now this is too deep. I don't think you will get asked this. Huh? And I'm just don't panic. Do you think there's an option, something to do for this lady? Let's say she's perfect, huh? Crohn's is completely optimized. يعني خلاص, Crohn's is controlled. What can you offer her? The fissure is not getting better.
Well, I cannot recall.
You don't know, don't waste time.
I don't know.
Okay, so I'll go back to it and then we're going to close. So let's talk about your answers very nicely. You went through the history, you asked questions, person's history, past family history. She told you she has IBD, then it's good. Then now you're suspicious. I like you already, as I was talking to you, you already thought about IBD and you start thinking as IBD as your differential, which is very smart. I'm hoping the reason you are thinking about IBD because I told you the fissure is in atypical position.
Lateral,
it's in the lateral. Normally the fissures are anterior or posterior. So when you have a fissure is in atypical position, you have to be suspicious. Is it cancer or is it IBD or is it anything else? And it would have been nice answer if you told me I looked at this fissure either in the EUA or in the clinic and I found some chronic signs of fissure like papilla, rolled edges, and things like that. But it's okay. You are okay. And then you are worried about IBD, then what you did a colonoscopy, a G-scope, and what I would do a CT interrography or MRI interrography. Oh. I think if you do this with CRP and ESR, you did the full package for GI. Now you do this, I would have told you the CT interrography showed stricture, mild, with the ileitis, you would have thought, that's very likely Crohn's now.
Yeah.
And then you did the EUA and you did the biopsy, it's fine. I'm not sure the skin tag will be useful. I think the ulcer-based biopsy is where you got your diagnosis. And then, which is great. Also, you talked about I pushed you, but you have to remember, your patient will wait for the colonoscopy for 6 weeks. You're not sure it's IBD yet. Give her some treatment. So in Kuwait, we don't have calcium channel blocker. I think it's only GTN. Yeah. So you can give her GTN with laxative and sits back. So you did this after I pushed you. Then now you're worried about IBD. You take the biopsy. It's IBD. You consult GI. Excellent answer. I would add flagell maybe. It will help with anorectal Crohn's disease. And then GI will take care of her for you. They will optimize her. She'll come back to you and she's still... And I loved your answer when you said very confidently, sphincterotomy will not work with you because your disease is not based on hypertonicity of the sphincter. It's because of ulceration from Crohn's disease. So if I cut your sphincter, nothing is going to happen. Because the idea for managing no patient with no Crohn's is that you cut the sphincter to reduce the hypertonicity of the sphincter. And it's not the pathophysiology of Crohn's. So it's a lawsuit if you do a sphincterotomy for Crohn's. It's a big lawsuit. Your career is over, okay? Then then what you do is, so the options you have, if you have somebody with fissure that is not getting any better, you can, if you think there is more space for optimizing medical treatment, it's always okay to discuss doing a diverting stoma so that there are no more stool pain. So that's one option. Second option is, this is very controversial, but you can answer it. It's in Sabiston, where you can do a fissurectomy with skin advancement flap. Because basically you're removing the ulcer and you're covering it. You're not cutting any muscle and you're taking the skin because now you know the Crohn's is optimized and controlled. You should not excise or cut through tissue in Crohn's if there is any active disease because it will not heal. But because this is why I stressed and I told you, the patient is optimized, is completely normal. Now you can do, and this is what I do for my ERAF, endorectal advancement flap. What I do is I wait until I want them to be fully normal, then I will do ERAF for a fistula and Crohn's. That's another question later. And one other thing, let's say if the ulcers are getting worse, they're spreading, you can always counsel them for a proctectomy, huh? What are you gonna do?
APR?
APR, basically, yeah. But that's really the last thing. And the reason you take the biopsy not only for Crohn's, also to make sure there's no cancer. That could be a cancer. I could have went with squamous cell carcinoma.
Yeah.
I think that's it.
Yeah,
sure.
thank you so much.
Thank you very much. Thank you very much.
Okay, so thank you everyone for for attending this lecture. Thank you so much, Dr. Ahmad Alkhamis. It was perfect. I'll just give the screen to Dr. Ali Khayat. He has two announcements to make for Surg Kuwait.
Hello, everyone. Thank you for attending this session. I hope you enjoyed it and benefited as much as I did. You can register for our next session on the QR code on the top left, and we have an international webinar on the return of elective surgery. You can register on the QR code on the top right. If you are looking from your iPad or your laptop, you can pull out your phone and just point it at the QR code, and it will take you directly there. Or you can go to any of our platforms at Surg Kuwait across our platforms, to Instagram, Twitter, website, Spotify, and podcast, where you can catch up on any webinars you missed. Also, we have another announcement that we're starting a new series of videos called Surgical Pocket. It will be short videos about surgical skills, where you can recap or on specific topics. Our first video is currently on by Dr. Munira Ben Nakhi about dressings and burns. It's a condensed 5-minute video that will summarize a lot about that topic. And await our future videos that will be posted on a weekly session. Thank you again, Dr. Ahmad Alkhamis. I've enjoyed this session so much. And thank you, Dr. Jude. And thanks again, everybody, for attending this session. Thank you for your support. The session is ended. We'll leave this QR code on for a few minutes if you want to register. Thank you.
يعطيكم العافية. السلام عليكم.